Morning dear students. Today we are going to discuss about the topic blood coagulation disorders in obstetrics. Control of blood loss from the vessels depends on the following factors such as muscular contraction, that is vascular contraction, that is causes vasoconstriction, myometrial contraction that adjacent to the vessels, tissue pressure, platelet function, and blood coagulation mechanism. So all these factors depends and helps the control of blood loss from the vessels. We can see the overview of blood coagulation. When the vessels get injury, platelet activation causes vasoconstriction that makes platelet plaque and makes the clot formation. Also, the tissue factor that causes coagulation cascade and thrombi formation. Both platelet plaque and thrombi formation makes the clot formation. Next, we can see the hemostasis. It is in the three steps, that is primary, secondary, and tertiary. First, primary hemostasis. Platelet plaque formation, that is depends on normal platelet number and the function. Secondary hemostasis occurs, that is through the activation of clotting cascade and deposition and stabilization of fibrin. Third, the tertiary hemostasis, that is dissolution of fibrin clot dependent on plasminogen activation. So these three steps that occurs in the hemostasis. Same like this, process of normal coagulation take place, that vasoconstriction, platelet aggregation, clot formation. You can see from this picture also, when a vessel get injury or damage, vessel vessel contracts and platelet plaque form and fibrin clot also formed. Now we can see physiological changes. Procoagulant factors markedly increase in pregnancy are factor 1, 7, 8, 9 and 10. Factors either unchanged or mildly increase are 2, 5, 12. And factors that decline are 11 and 13. Now we can see the physiological changes in the pregnancy. During pregnancy, there are increase in concentration of clotting factors such as factors 2, 5, 7, 8, 9, 10 and 12. And plasma fibrogen level is significantly increased, and there is a small decrease in the platelet count due to low grade intravascular coagulation. And plasma fibrinolytic activity is suppressed during pregnancy and the labor. It returns to normal within 1 hour of delivery of the placenta. So after the delivery of placenta, this fibrinolytic activity will become normal after the labor. And this is due to the liberation of plasminogen inhibitor from the placenta. So when the placenta is separated, normal coagulation activity will occur. Next is the pathological conditions of acute coagulopathy. So what are the pathological conditions that causes the coagulopathy? Endothelial injury. So what are the causes? What are the reasons for the endothelial injury? What are the reasons that cause the endothelial injury? Such as preeclampsia, eclampsia, HELLP syndrome, septicemia, such as septic abortion, chorioamnionitis, pyelonephritis, and hypovolemia that causes the endothelial injury. Next is the release of thromboplastic, amniotic fluid embolism, dead fetus syndrome, abruptio placentae, hydatidiform mole, caesarean section, intra-amniotic hypertonic saline, and the shock. These all causes release of thromboplastin. Next is a release of phospholipids. Fetal-maternal bleed. If the fetal-maternal bleed occurs, there is that causes release of phospholipids. And incompatible blood transfusion, that is the mismatched blood transfusion, and hemolysis. All these three reasons that causes release of phospholipids. All these clinical conditions may trigger the delicate hemostasis mechanism either by endothelial injury or by release of thromboplastin and phospholipids. Till now, these are we seen in the previously we seen what are the causes that makes the endothelial injury and release of thromboplastin and the phospholipids. It is always secondary phenomena and never the primary causes because of the hypercoagulable state in the pregnancy. So usually the pregnancy is a hypercoagulable state. Okay, and the presence of any provocative factor. Factor means any factor that causes or provoke them to bleed can easily upset the normal balance, culminating into disseminated intravascular coagulopathy. It is sometimes called defibrillation syndrome, but because either constituent factor besides fibrin are also consumed, a better nomenclature would be consecutive coagulopathy. The blood fibrinogen level of 100 mg per 100 ml is arbitrarily considered to be a critical level. So these are the factors that causes the coagulation failure. Next, we can see the mechanism of acquired coagulopathy. First is abruptio placentum. So when there is abruptio placenta, what is abruptio placenta? It is a separation of the placenta which is before the tip. That is the abruptio placenta. So when there is abruptio placenta, the massive retroplacental clot formation will occur. Not only the fibrogen along with the other procoagulants is consumed in the clot. So, but after the clot retraction, the serum component is absorbed in the circulation. So, when the serum component is absorbed in the circulation, thereby further reducing the circulatory procoagulant. And this will lead to thromboplastin liberated from the cord. When the thromboplastin liberated from the cord, it damages the residua and the uterine musculature and enter into the circulation and produces disseminated intravascular coagulation. Because of precipitating shock, synthesis of essential coagulation factors fails to occur promptly. That also lead to the massive bleeding. And fibrinolysis, serves as a protective mechanism to dissolve the fibrin clot so as to restore the patency in the microcirculation. So when fibrinosis occurred, the clot formation it dissolve the clot formation. So the circulatory and the vessels will become patent for the circulation, and level of fibrin degeneration products is raised, and so because of all these factors it inhibits myometrial contraction. We already told due to this myometrial contraction the bleeding will be stopped. Okay, so but because of all these factors and the level of fibrin degeneration product raises, that inhibits that will obstruct the myometrial contraction. So that causes myometrium could not be contracted. That's why that causes the bleeding. Next is the liquor amni embolism, otherwise known as amniotic fluid embolism. We can see the mechanism. When the amniotic fluid enter to the medullary circulation, either by through a rent in the membrane or the placenta, because of any amniotic fluid test. When we are taking the amniotic fluid for testing, when there is a prick or injury into the membranes or the placenta, this amniotic fluid is entered to the medullary circulation. So this amniotic fluid which is rich in thromboplastin. Okay, and also it contains debris. Okay, so when this debris blocks the pulmonary artery and triggers the complex coagulation mechanism. So when the thromboplastin rich liquor amni that containing debris that enter to the pulmonary arteries and trigger the complex coagulation mechanism, that will furtherly lead to the DIC. And there is massive fibrin deposition distribution throughout the entire pulmonary vascular tree will occur. And if the patient survives from the severe pulmonary embarrassment, which stimulates thromboembolic phenomena. There will be severe clotting defects with the perfuse bleeding per vagina or through the venopuncture site due to the conception of the coagulation factors. From the damaged endothelium of the pulmonary artery, massive fibrinolytic activators are produced, which excite the fibrinolytic system, converting the plasminogen to plasmin, which in turn produces lysis of fibrin, fibrinogen, and even the factor 5 and 8. Thus, there is secondary fibrinolysis on top of primary fibrinogen depletion arising out of disseminated intravascular coagulation. Next is endotoxemia. The mechanism is prior to the development of shock, there appears a hypercoagulable state which adversely reacts with the presence of endotoxin leading to disseminated intravascular coagulation. And the phenomena is comparable to generalized Schwarzmann's reaction, that is a hyperreaction. The difference is that a single stimulus instead of a two is enough during the pregnant state to produce the reaction. So there is no actually it is a single stimulus, but in the pregnancy there is a two is there to state this reaction. There is extensive DIC including deposition of fibrin in the renal vascular system. Then in the shock stage, first is the prior development of shock, second is the in shock stage. The endothelium of the capillaries in the microcirculation is damaged due to the anoxia, associated stasis of blood fevers. It also causes disseminated intravascular coagulation. And increased production of activators from the damaged capillary endothelium that means interfere the fibrinolytic activity and causes defibrillation and also causes the severe bleeding. Next is retained dead fetus. So that is the fetus dead and retained in the uterus. The fall in fibrinogen level is gradually and usually become evident following the retention of the dead fetus for more than 4 weeks. Defibrillation is likely to be more following retention of the dead fetus. The baby dead and retained into the uterus, there will be defibrillation when the dead fetus remains due to the RH incompatibility. There is gradual absorption of thromboplastin liberated either from the placenta or from amniotic fluid or the decidia. This results in depletion not only of fibrinogen but also the factor 8 and platelet. In response to DIC, there is enhanced fibrinolytic activity which in turn reduces the fibrinogen level further. Dead fetus with the living twin is a hazard for the living fetus rather than the mother. So if it is occur, more problem for not only for the mother, more than that is a problem for the live fetus, live baby. It is a retained dead fetus. Next is the installation of intra-amniotic hypertonic solution. So if the intra-amniotic hypertonic installation occurs, that will lead to thromboplastin released from the placenta. That causes thromboplastin to release from the placenta and the fetus and the decidia. So from these routes, the thromboplastin will releases, and due to necrobiotic effect gains and accesses into the circulation and causes defibrillation. So there will be, if there is a defibrillation, that causes DIC. Next is a cesarean section. When there is cesarean section, primary defibrillation following cesarean section may be due to so when the cesarean section occur, there will be primary defibrillation occur. It is because of entry of thromboplastin or amniotic fluid into the circulation. There may be accidental injury to the blood vessels, and this amniotic fluid may or thromboplastin may enter to the circulation through the open vessels on the uterine wound, and also from the excess production of plasminogen activators from the injured uterine site. So from the injured uterine site there may be excess production of plasminogen activators. So all these two factors causes primary defibrillation when there is a cesarean section. Next we can see the clinical manifestation. The clinical manifestation are before delivery and the after delivery can be classified. So before delivery there is a signs of bruising, prolonged bleeding at the injection site, gum bleeding, hemorrhage from the gastrointestinal tract and hypotension. After delivery, there is a postpartum hemorrhage. Actually, when the uterus is relaxed, not contracted, but the postpartum hemorrhage will be occur. But in this case, due to the coagulation failure, that time the uterus will be hard and well contracted. But also there is a postpartum hemorrhage. Okay, then the hemorrhage usually occurs 1 to 2 hours following the delivery. There may be bleeding from the suture site, that is episiotomy wound or hematoma formation in the abdominal wound following cesarean section, or formation of the vulval hematoma following the vulval vaginal delivery. These are the clinical manifestations that usually occur before delivery and the after delivery. Next we can see the investigation. So bedside tests that may be done are usually in the bedside near to the patient, that is done are bleeding time, clot observation test, peripheral smear, circulatory fibrinolysis test. So we can see the clot observation test. It is usually done in the bedside test. Can be repeated 2 to 4 hours interval. How it is done? We can see that 5 ml of venous blood is placed in the 15 ml dry test tube and kept at 37 degree. Usually blood clots form within 6 to 12 minutes. The test provides a rough idea of blood fibrinogen level. If the clotting time is less than 6 minutes, fibrinogen level is more than 150 mg%. And if no clot forms within 30 minutes, the fibrinogen level will be probably less than 100 mg%. Then next is the peripheral blood smear test. So peripheral blood smear test, when stained in the right strain, may be held if less than 4 platelet per high power field are seen, thrombocytopenia is diagnosed. If the 4 platelet per high power field if we see, can be diagnosed as thrombocytopenia. We can be find out. Then thrombocytopenia is the feature of DIC but not fibrinolytic process. Next is RBC morphology. It is also done by the peripheral smear. So in DIC the cell shape will be helmet shape. Normally there is a cell morphology is normal, but if it is DIC the cell shape will be helmet shape. Okay. Next is the essential laboratory test can be performed to know what is the specific defects of coagulation mechanism. So it is the first is platelet count, then second is partial thromboplastin time, third is prothrombin time, fourth is thrombin time, and fifth is fibrinogen estimation, and sixth is fibrin degradation products, that is FDP, and seventh or the final one is the D-dimer, that is a breakdown product of fiber. That is the these are the tests are done to perform or to find out what is the specific defects for this coagulation problem. Next is a treatment. Abruptio placenta. If it is abruptio placenta, massive blood transfusion should be provided. Then to expedite early delivery by low rupture of membrane, we have to done by the early delivery by low rupture of membrane and supplemented by the oxytocin 3. And next is liberalization of the cesarean section. We can do the by the cesarean section and take out the baby. If the intrauterine death, we explained the dead fetus, expectant attitude is reduced. We should not expect for the baby to come out. We have to availability of a potent oxytocins to empty the uterus. So we can provide some oxytocins, that is prostaglandin, and make the baby to come out. We can go for to deliver the baby. Then better understanding of the pathophysiology of the shock and early institution of appropriate therapy. So we have to understand, or we have to find out what is the cause of the shock, and we have to do the management appropriate to the cause. Then acute fulminating preeclampsia, eclampsia, and HELP syndrome have been substantially reduced by the effective care. Avoiding installation of hypertonic saline. We already explained it is one of the cause for the coagulation failure. So that's why avoiding installation of hypertonic saline for induction of abortion. Then infusion of molecular gelatin, that is a hemacil, or gelfusion as plasma expander, avoiding extran. Extran we have to be avoid, and we can provide some hemacil or gelfusion. Okay. Then emptying the uterus and controlling the infection only with the antibiotics. So we have to start any type of broad spectrum antibiotics should be started to empty while we are emptying the uterus. There is a chance of getting introducing the infection. That's why we have to start some antibiotic. Then adjuvant therapy, that is vitamin K to control the bleeding. So vitamin K dependent factors are 2, 7, 9 and 10 are consumed in DIC. So 5 to 10 mg of vitamin vitamin K is given IM. It can be helped to replenish these procoagulants. Next is curative management. The management goal is to identify and to correct the underlying pathology. So we have to the main goal of the management is to we have to first identify what is the cause, and next to correct the cause. In most cases, in most of the conditions, after delivery of the fetus brings the resolution of the coagulopathy. So after delivery of the baby, normally the bleeding will be this coagulation will be corrected. The other part of the management is to achieve a platelet count. So the platelet count will be if it is more than 50,000 and the fibrinogen level is more than 100 mg per deciliter. The management is according to the level of platelet count and the fibrinogen level. The actual management, first we have to replace the volume replacement. Second is blood component therapy should be given. Heparin can be started and fibrinolytic inhibitors should be provided. So first, volume replacement therapy. How can we replace the volume of the blood? First, crystalloids, that is Ringer solution, or by the colloids, hemacil, gelfusion or human albumin 5% can be provided. It will reduce the amount of whole blood needed to restore the blood volume. The crystalloids remain in the vascular compartment less compared to the colloids. Then dextran should be avoided as they adversely affect the platelet function and blood cause matching test. So that's why dextran should be avoided. Then 2 large bore IV catheters are situated. We have to start. We have to insert 2 IV cannulas. Next is the whole blood transfusion. 500 ml of fresh blood raises the fibrinogen level approximately 12.5 mg per 100 ml. And adding 10,000 to 15,000 platelet per cube. That's why whole blood is rarely used in modern obstetrics due to some disadvantages. So next is the fresh frozen plasma. It is extracted from the whole blood and it contains fibrinogen, antithrombin 3, clotting factor 5, 11 and 12. So fresh frozen plasma transfusion provides both volume replacement and coagulation factor. So 1 pint of FFP, that is 250 ml, raises the fibrinogen by 5 to 10 mg per deciliter. So FFP does not need to be ABO or RH compatible, and cryoprecipitate is obtained from the wet FFP, and it is rich in fibrinogen factor 8, von Willebrand's factor and 13, And cryoprecipitate provides less volume, it is 40 ml compared to the FFP 250 ml. So FFP will be available in 250 ml, but this cryoprecipitate is 40 ml. So it should not be used for volume replacement. So 1 unit of cryoprecipitate increases the fibrinogen level around 5 to 10 mg per deciliter. We already it is in the fibrinogen also, FFP also fibrinogen will be 5 to 10 mg, and cryoprecipitate also increase the fibrinogen level to 5 to 10 mg per deciliter. Next is a platelet concentrate. It may be given to the patient with very low platelet count, that is less than 50,000 per ml, and persistent bleeding, continuous bleeding. So platelet should be given rapidly over 10 minutes. It should be ABO or RH specific, and transfusion of a single unit of platelet is expected to raise count between 5,000 to 10,000 ml. So if we provided one single unit of platelet, it will be increase the platelet count, that is 5,000 to 10,000 ml. Then in case of sensitization, RH immunoglobulin 300 mg is given, and several units of platelet concentrates are to be transfused, as 1 unit 50 ml raises the platelet count by 7,500 per ml. And single donor concentrates are preferred as a immunogenic and antigenic risk as low. Next, packed red cell, that is PRBC, are most effective to improve the oxygen carrying capacity. So oxygen carrying capacity is reduced when hemoglobin level is less than 8 gram per deciliter. We already know the oxygen is carried by the hemoglobin. So even in the euvolemic patient, then transfusion reaction are less compared to whole blood transfusion. So each unit contains about 300 ml. 1 unit of PRBC will raise the hemoglobin level by 1 gram per deciliter and hematocrit by 3%. Recombinant activated factor, that is 7A, that is 60 to 100 mg per kg IV, can reverse DIC within 10 minutes, as it is a precursor for extrinsic clotting cascade, so which is replaced. Next, auto transfusion. It is the transfusion of the same blood to the same patient. Auto transfusion is a collection of blood from the operative field, filter, and the same blood is then transfused to the red cell back to the patient. In the device of auto transfusion is called cell saver. The advantages are less risk of infectious disease transmission and immunological reaction. Next is the alternative oxygen carriers can be used when compatible blood products not available or cannot be used. Hemoglobin based oxygen carriers and perfluorocarbons have got high oxygen carrying capacity. Next is a heparin. It should be used when the vascular compartment remains intact. In acute conditions such as amniotic fluid embolism, I already explained you, that is amniotic fluid enter to the circulation and it will causes the DIC. Then intravenous heparin 5,000 units repeated 4 to 6 hours interval is useful to stop DIC and may be life saving. In retained dead fetus, there is a progressive but slow defibrillation due to DIC will occur. In such cases, the process can be arrested by intravenous heparin. Next is fibrinolytic inhibitors. So commonly available antifibrinolytic agents are EACA inhibits the fibrinogen and plasmin. Triazolol that inhibit plasmin. Aprotinin, that is non-specific enzyme inhibitor. So all these are the main antifibrinolytic agents. The fibrinolytic inhibitors are mainly indicated in postpartum hemorrhage following abruptio placentae in spite of a firm and contracted uterus and when blood fibrinogen level is 200 mg or more. That is can be provided fibrinogen inhibitor. Come to the conclusion. Till now we discussed about the coagulation problems in the pregnancy and what are the factors causes the coagulation factor and how can we prevent it, how can we manage. So, prompt replacement of blood volume and coagulation factor is an important step in the management of coagulation disorders in obstetrics. Management of the trigal factors should be done along with. This will improve the hemostatic competence in vast majority of cases. With adequate perfusion of vital organs, not only the activated coagulation factors and FDB are promptly removed by the reticulo, but there is accelerate synthesis of procoagulants, especially by the liver. That's all about the coagulation problems during the in the obstetrics. I think all of you are clearly understood. Thank you.